Welcome. Let's talk about weight loss in obstructive sleep apnea patients. Now consider a couple of scenarios. One, a patient has recently been diagnosed with sleep apnea and wants to know more about weight loss as a treatment strategy as opposed to using CPAP. And another patient has been on CPAP and is starting to lose weight and wants to know if they need to be on CPAP for the rest of their lives. So let's consider the idea of weight loss. Now I definitely consider weight loss as a go-to strategy. Now, weight loss will always be something that I recommend patients, especially if they're obese or overweight, especially if they have concurrent comorbidities, regardless of whether they have obstructive sleep apnea. Now, there are a couple of times, there was one thing that I want you all to understand as well, is that in patients, I don't want it to be where it's weight loss versus treatment for sleep apnea using CPAP or mandibular advancement devices or even lateral positional therapy. Now, it's not usually a case of one or the other, but I normally use it in conjunction. Now, obviously, if a patient has an AHI of above 15 or even AHI above 5, along with comorbidities, then I would recommend immediate treatment. Now, one aspect of weight loss is pretty simple to comprehend, but we have to consider both sides of the coin: weight loss versus actual weight maintenance. So if a patient is able to lose weight, that's one thing, but if they're able to maintain that weight loss, it's going to be equally crucial. So for example, if someone's already on CPAP and they lose weight, they may find the pressure setting overwhelming because the pressure was set based on a CPAP pressure based on their previous weight. However, as with weight loss, they may require a lower pressure setting. But I would suggest waiting about 3 to 6 months of weight stabilization before ordering a repeat sleep study with titration. The sleep study part of it to assess whether they actually have sleep apnea after the weight loss, and if they meet criteria, to go ahead and titrate them based on the lower pressure settings. Now, obviously, if a patient has the benefit of already being on AutoPAP, then you can just change the pressure settings to 4 to 20 centimeters of water and let the machine's algorithm decide which pressure setting works best for the patient. Now, you may also want to consider AutoPAP in patients that you start off treatment for sleep apnea for, because especially if they have a history of frequent weight loss, of weight fluctuation. But also, most of the time I put most of my patients now on AutoPAP due to the change in weight. As they get older, sleep apnea may get worse, change in medication, sedatives and so on, or even use of alcohol in between, all of these kind of worsening your sleep related breathing disorder or breathing episodes. So AutoPAP would be another strategy to use, especially in patients that are losing weight. And if that doesn't work, you can always, if they have a CPAP machine, again, when their weight has stabilized after 3 to 6 months, to consider a repeat sleep study with a baseline portion along with a titration study. Now, when you do consider someone as well for weight loss, I strongly recommend, and I get most of my benefit in having a nutritionist involved as well. Now, if a patient has adequate health literacy and they're able to fend for themselves, you can just test them in the office as well, the idea of what nutrition is all about, calories versus the quantity of food that they take and so on. But a nutritionist is a great member of your team to kind of aid in weight loss, because he just doesn't want to mention weight loss and let the patient fend for themselves, especially nowadays where walking through a supermarket aisle requires you to have a bachelor's in biochemistry, just because even I don't understand a lot of the stuff that goes into many of the foods that we consume. But the other consideration, and some people may find this a little aggressive, is bariatric surgery. Now, the current recommendation is a BMI of more than 35 with comorbidities, or if you don't have comorbidities, and a BMI above 40. But again, if you have a BMI above 35 with comorbidities, then you may recommend or consider a bariatric surgical evaluation. Those are two options on the table. I leave it to you to discuss with the patient. Thank you.